We know that BTK inhibitors are a commonly agent used against B-cell malignancies, in particular chronic lymphocytic leukemia. Ibrutinib was the first-in-class BTK inhibitor. It is a highly active agent in patients either with relapsed refractory diseases or treatment-naive patients. However, some of them can develop important and relevant adverse events which must be managed in the corrected ways in order to treat the complication and let the patient to continue the treatment. Some of the most common adverse events with BTK inhibitors are atrial fibrillation, bleedings, and hypertension. We know that there are some risk factors associated with the development of atrial fibrillation, in particular elderly patients with comorbidity, in particular other cardiovascular diseases. The Italian group of CLL developed an atrial fibrillation risk score to predict the risk of a patient to develop atrial fibrillation during Ibrutinib treatment. Known variables associated with increased risk of atrial fibrillation with Ibrutinib are also infective event, bronchoectasia, and some other common comorbidity, which summoned together can allow the physician to understand whether this patient could be at a higher risk to develop atrial fibrillation during Ibrutinib treatment. Second and third generation BTK inhibitors are more selective agents, so that is Acalabrutinib and Zanubrutinib. We are known to be highly active in CLL patients, to be highly specific they are more specific against the BTK inhibition, not targeting ITK, which is expressed in T lymphocytes or on platelet functions. So with these novel agents, cardiovascular events are lower, in particular atrial fibrillation, but also bleedings, that we can observe less bleeding events. So hypertension is less common. With Acalabrutinib, we know that this agent is able to trigger a novel adverse event, which is a headache, which is quite common in patient treated with Acalabrutinib, but all these events are not of severe grading. Other common adverse event is infections. We know that the disease is still a problem in patients with chronic lymphocytic leukemia treated with BTK inhibitor, because actually the range of all effective event ranging between 20 to 25% of patients. So it is not an uncommon event. Which is only partially dependent on BTK inhibition of T lymphocytes. Of course, they are more common in relapsed refractory patients than in treatment-naive subjects. And finally, all these adverse events impair the treatment. So some of these patients must discontinue treatment. In our abstract, almost 23% of patients discontinue treatment with Ibrutinib due to adverse events. The cumulative incidence of discontinuation for the whole cohort was 32%, but it was 26% for patients due to adverse events. And we observed that patients who discontinue Ibrutinib due to adverse events had a shorter progression-free survival, but most importantly, they had a shorter overall survival.